Well, hello, everybody. It's so nice to be on the East Coast. I got a chance to wear my coat I bought like 3 years ago. All right, what you don't know behind the scenes is that she and I are both jet lagged because we're jet setters now, because all the meetings started again. So we're kind of tired. If I pass out, just throw some water my way. Okay, I don't have any direct conflicts except that AA is really passion for me. We have members of the board for NAAF here that I want everybody to meet later on. I am vice chair now. They changed my title, no raise. All the money still goes to the university. It's a public university. But don't worry, I am consulting on the side. I do have to give 10% of my proceeds to the university, which I don't like, but it is what it is. And Chief Scientific Officer for NAAF. I have this gift of simplifying or dumbing down stuff. You will get your science, but it's just going to be kind of my storytelling way. What is the whole pathogenesis story and why do we care? When patients really come in the first time, like, what do they ask, right? Why me? Why? What would cause this hair loss? And then what does it mean? What else is going to happen to me? And I'm just thinking, like, yeah, I don't know how to answer these. And then the one question they always have is like, is this forever? Like, is this what I'm always going to have? And what I usually tell them and break them down is, this is what it is. It's a common thing. Patients have it. Boys and girls, it affects young people. Life is not necessarily going to be simple, but it's part of this whole rising trend we see in autoimmune diseases. We see thyroid disease, we see everything. Are we too clean? Are we not? We don't know what the story is. So how do we help answer these things? Demographics are changing the more we're understanding. The whole picture of diversity is something that the NAAF and everybody that does alopecia areata is a little bit vested in, because especially in the United States, we do tend to have higher odds ratio for having the condition in people that are African American descent versus Asians. A recent study just came out of Britain where actually it's the highest seen in that part of the world in the Asian groups. When you have a chance, I would really suggest that you look at this article. It's called Hair-Raising History of Alopecia Areata. It's very cute because it kind of gives you this whole story, the evidence of having even this kind of bite hair loss that was alopecia areata from Egyptian times. And the thing is that through the thousands of years, the way it was treated was to irritate the scalp and then to cause scarification. So kind of the modern day immunomodulators and lasers that we use. So 3,500 years, they didn't have dinosaurs, neither we, but things haven't really moved too much until recently. First medical description is this. Why am I kind of throwing these things? Because as we're trying to figure out how this pathogenesis happens, these are the old school thoughts that are still prevailing in the why me, why is this happening? Is it infection? Is it my teeth? Is it the toxin? Is it vitamins? Is it my thyroid? It was in the 50s that we realized that the steroids can do this thing and then that it's connected to the autoimmune stuff. And really it was in the past 50, 60 years that we are calling this an autoimmune condition. So what is the mechanism is really what are the mechanisms of this condition. And this nice review was published recently which just says, it's an autoimmune disease with multiple players. Or may I say, is it just a reflection of many different ways you can get there? Because I personally am not sure that one with the next patient are the same. Just like Dr. Gutman said, like atopic derms, if they have atopic derm, I like it, because I think I can do something about it, versus if they have inflammatory bowel and psoriasis. So just different subsets of patients, but maybe they all have things. So what is the agenda for my Areata players? This is the oversimplification gift. The genetics, the triggers, and then the loss of immune privilege. Well, you got to hear, that gets to that loss of immune privilege around the hair follicle. You got to hear all the stuff that happens at the kind of basic science level. The thing that's always, in a way, puzzled me is like, what is this immune privilege? What the hell does this mean, like loss of immune privilege? It's an ability of certain parts of the body to avoid being recognized by the immune response. And it's reserved in the body for things that are very important, such as the brain and the testes. So ovaries I couldn't find. But hair follicle is also in this whole thing. Why? Because probably the stem cells. I think there's some sort of a protection there that I can speculate. And it's really maintained very wisely by our bodies, simply because there's no lymphatics next to it. There's all this thick extracellular matrix to protect it. And then there's all these ways to suppress immune cells that are lurking around to just leave you the hell alone. Because the end of the game in this, because it's still type 1 inflammation, considered to be, is to kind of keep that interferon gamma production away. Because what happens when alopecia areata happens? The type 1 inflammation is that there's this hypersecretion of interferon gamma, then you have all this kind of cascade of immunological events that lead to the very famous, infamous swarm of bees that happen, the inflammation around the hair follicle that causes alopecia areata. Very eminent in the first and initial phases, but then goes away later. So right now, I'm just going to tell you about the genetics, and we're going to talk about the triggers. Why genetics? Why do we care? Because family history of alopecia areata actually shows that you have a higher chance of getting alopecia, even if your kids have it. If your parents or siblings have it, you're around 7% versus 2% for the general thing. So these are a picture of two sisters. We were treating the little one. The parents went through a painful separation, then the older one lost her hair too. So I ended up with two AU girls. Monozygotic twins do tend to have higher concordance. These are some of the alleles that have been mentioned. The interesting thing is that every time we see HLA, we always think autoimmunity, but actually certain loci have been important in keratinization, so maybe there's also structural stuff. From GWAS studies, a lot has been found. So these are the list of things. Not because I want to show you how smart I am or that I read patients, but because it's very important for all of us to recognize these things because they do come in handy. For the one thing that I will use as an example today is really some of these things like CTLA4. We used the Batacept in studies and it didn't really turn out to be a great thing. But I will tell you for an example, a patient that I just had that it proved to be very useful. The bottom line of this whole list is there's no monogenic cause. So that still kind of testifies to the diversity of the patient population. The importance of CTLA4. So most of you, if you've seen alopecia areata, some of these kids come in, they're kind of pale, they may get colds and coughs, they may have eczema, right? This is a story of a young girl who was an A student, had a little bit of eczema. It's kind of like the sickly kid. And we diagnosed her with this condition serendipitously, and it wasn't really me. This is a whole subset of these primary immunodeficiencies that are now very fancy. People can do testing and recognize them. They start out early in life, but they're very hard to pick up. Why? Because, as I said, the kids come in, and it's kind of like the sickly kid that just gets cold and sniffles. They get these sinus and ear things, so upper respiratory, so nobody really cares about it. They may be a little bit anemic. Nobody goes and chases the hypoglobulinemia. They may have achy bellies, which if you ever have the chance to come to a patient conference, you will hear the parents. They stand up and they say, my baby's belly hurts, but nobody wants to work it up or we don't know what it is. Well, this girl had belly pain for many years and then at age 17 developed colitis. I'm just showing you these kind of like small things that we tend to push aside because they're not common, but nowadays we have ways to tie them in and bring them together. And she always suffered from headaches, which is a very common thing, especially migraines with these haploinsufficiencies. She was diagnosed because she developed very severe headache with focal symptoms. She ended up in the hospital and had lung and lymph nodes, and they biopsied them and they showed these lymphocytic lung infiltrates. We look at these kids who have alopecia areata, who have this life tendency, 73%, to develop these lymphocytic kind of lymphoproliferation that so far we think are mostly non-malignant. This girl is now on a Batacept trying to improve the rest of her. Her alopecia areata is getting a little bit better. But what's the point? The point from the genetic studies is really something that we're learning more and more in these patients. The whole dogma of like, you have autoimmune condition, that means you're not necessarily immune deficient, does not hold anymore. Because this is an example of these paradoxical situations where we have autoimmunity and immunodeficiency. And they're a little bit challenging to treat. So what are some of the other triggers that we can talk about? The triggers usually are divided in environmental stuff in all the literature, meaning like stuff that you're exposed to, like stress, allergies, infections, but really they translate into the comorbidities that are corresponding with the body. So this is a point of debate, and I think Dr. King is in the back, and we've had all this at many of our meetings. Is it all from stress? That's patient's favorite question. Did I do this to myself? Is it because I stress out? And we don't argue, but we debate amongst each other because I think stress has something to do with it, but there's really few clinical studies. So people, they say, Natasha, I don't think so. There's really not much in the literature to support it, that chronic stress or stressful life events do this. Certain dermatology associations and bodies say that really the role of mental stress in AA should not be overemphasized, and I do agree with that. But is there evidence for stress in alopecia areata, and what is it? There is a connection with the HPA axis and the secretion of neuroinflammatory stress mediators. The things that I want to point out in all of these is really that stuff like corticotropin-releasing hormone leads to degranulation of mast cells. Substance P, neuropeptide, mast cell activation, antigen-presenting cell accumulation. Nerve growth factor, again, mast cell activation. So all of these things, in a way, kind of recruit a little bit of inflammatory milieu around the things, and I will show you why that's important. But aside of stress, what's the comorbidity that's connected? It's really the psychiatric health in alopecia areata patients, and that is the anxiety, the depression that is really common in the patient population, right? So we can't really say that there's no connection. When it came to depression in alopecia areata patients, we always thought you lose your hair, of course you're going to be depressed, like life is different. However, a 6 million people kind of a network UK follow-up for 26 years showed that not only does AA cause you to have depression, but having depression is a really high risk factor to develop alopecia areata. And that patients that were treated with antidepressants had a protective effect. So some of the stuff that Dr. Gottman said, like treat early to prevent. Then looking at some of the soldier studies in PTSD, increased risk, 5 autoimmune skin conditions, alopecia areata is one of these skin conditions that are associated with PTSD. ADHD, bunch of kids that start Ritalin, they may have alopecia areata. Patients are asking, is it the disease, is it the medication? Taiwan, a large study actually said it was the ADHD that had a higher risk, so is it this kind of constant stimulation that may be there? I'm not quite sure, but they didn't see that there was any reduction in risk with treatment the way it was shown in the depression. So when it comes to stress in alopecia areata, what's the future and what are we going to decide? Well, one of my favorite papers came out in 2019 out of MGH. So Marianne, you got to do this future goal. And it's her chair of the department where they showed that if you really torture mice, and if you really want to know why you're depressed, see what they do to mice. They flick lights, they poke them. And it's the ones that like have social, kind of like you don't know where you stand, the limbo in life, so if your boss messes with you, how they turn gray. So maybe what all of you East Coasters can do is reproduce the study conditions in like an alopecia areata model. So then we can get to the bottom of it. When it comes to infectious triggers, such as viral infections, this is something that people have talked for a long time. It's been reported to be associated with alopecia areata. Some of the latest, more plausible kind of mechanism is that it has to do something with the plasmacytoid dendritic cells. These are some of the viruses that have been implicated with our newest baby on the block, SARS-CoV-2, and I will show you some of the COVID pictures. And then the whole issue of vaccination. This is something that comes up at the patient conferences because there are a lot of kids. Remember, this is a young people disease, so parents always ask, parents are always worried. And there's not much in the literature, but it is a speculative factor and a similar scenario as in the infection. But I will go over some of the vaccines, and I actually, so this doesn't leave this room because I don't want to be responsible. So an article came out in the JAG that said that people with COVID don't necessarily have alopecia areata or lose it. This is a lady who's beautiful, young, I'm not going to say, whatever. She had long blonde hair and had a very mild case, and within 4 weeks, this is what she looked. And this is her at 16 weeks. So this is just a mild case, no prior history, maybe mild seasonal allergy. This is another patient that kept coming to me for like TE on an old biopsy. Mild case, again, within a couple of weeks, just shed diffusely, and then she had this round, big patch. I biopsied it again, and it came back consistent with TE. I mean, now it's not the perfect picture of the patch, because whatever, I was biopsying, and it's, but she did have round oval patches, but it came back as TE. So my whole question to you is, my medical director said that my colleagues are not happy with me because the wait list is too long, and they have to see hair patients, and I'm like, get used to it. Because look at the top 5 things for long COVID. Hair is number 4. It's more common than dyspnea. So we're going to keep seeing these patients, but everything we're reading is that it's telogen, but is it just telogen? How is this immune response? Is this a little bit more of alopecia areata? Remains to be seen, but this is some of the stuff that is coming in lately. This is a patient that was on methotrexate for a couple of years, not my patient for the methotrexate, but she received her immunizations, and this is what happened within a couple of weeks. She was stable before. These are patients that I have in clinic from which I could find who literally start losing a little bit of hair even after the first shot. We've received multiple calls at NAAF, the headquarters, from members saying, I shed after the first one, should I get the second one, is it going to happen? So these are the stuff that I want to kind of not scare people, but it's real, so people should know. So I have the conversations with my patients. When you get it, this is what it is. Yesterday I had a patient that came with a Johnson & Johnson. 3 days after she had it, she developed patches for the first time in her life. So it is something that we should be aware of, and we shouldn't deny it or ignore it for patients. So what am I suggesting? I'm like, maybe come in right after it's intralesional or do a couple of days before in a way to prevent it and start what it is. We'll see. I only have 3 to 6 month follow-up for some of these. Some are not regrowing as well as they were before, but definitely better than the ones that had the real COVID rather than the vaccine. The other comorbidity that Dr. Gutman talked about is the allergies. Historically, this is a type 1 inflammatory disease. Atopic dermatitis is type 2, but there's this strong correlation and strong subset. IG, 100%. In all of the trials where there's a high IG, you can always follow it, I feel, with a JAK inhibitor and see how it goes down to see if the hair is growing. If I see the IG going down, I'm like, I think there's a chance for you to grow. This is the data for the children and from the adults, and number one is you saw some of this on Dr. Gutman's stuff. It is atopy and then the autoimmune stuff, which I feel are a little bit of a different scenario in patients. What do we know from alopecia areata histology? That there's eosinophils around the hair bulbs, and then there's mast cells. So remember all that stress stuff when I was highlighting those mast cells? This is why. These are things we don't talk about much because they're not there, but we don't biopsy alopecia areata, so don't forget it. Dr. Costello-Socio is going to talk to you later, but this is about the seasonal patterns in alopecia areata, and I always put this, I think, in most of my talks. Why? Because a lot of people tend to shed when allergy season is high, springtime and fall time. Dr. Costello-Socio actually correlated the flares in the pediatric population CCs with the timing of their atopic dermatitis flares, and this overlapped. This seasonal kind of distribution in flares has been shown in some other countries and in Asian continent, and she's actually doing some other new fun stuff where she's trying to even figure out, like, what are these climate variables? Is it the pressure? Is it raining? So maybe we'll hear some of that today. This is why I like antihistamines in alopecia areata, and as I said, I get excited because I think they do help some of the chronic shedders. But even the more excited stuff is, without being redundant, is that dupilumab data that Dr. Gutman was talking about. Many publications out there, most of the stuff that's there is her articles that are nice and long and studies and a lot of little case reports on the new onset. So this is an example of dupilumab from one of the early cases in somebody with atopic dermatitis. So I think there's still a good option for people that have atopic dermatitis and alopecia areata, and we'll hear more about it today. About this causing alopecia areata is kind of when you give psoriasis, TNFs, and then people develop psoriasis if you give it for another indication. We do see some sebaceous gland atrophy, so maybe it's not necessarily a true alopecia areata, it may be just more like a drug-induced. There was a very nice article that came out of Dr. Britt Kreglow's stuff in children with atopic dermatitis. I like what you said about this not being a sprinter, being a marathoner. So whenever somebody goes on dupilumab for alopecia areata, you have to tell them it's going to take a while. JAK inhibitors, you get to see stuff 6 to 8 weeks, at least like a little bit of a pimple or a little bit of a peach fuzz starts popping up. This is longer, so just so people know. The other thing that's always been discussed and in pathogenesis, and the one that everybody likes to talk about, is really the microbiome. It's been all the rage in the last 5 years. It's died down. The one thing is, like, when we created all these registries when I was in Cleveland Clinic, I swear every time I would look at alopecia areata, there was like reflux GERD. We didn't even put it in because it was so common. And then these studies came out, and I'm like, holy smack, I should have really noted that down, but I just didn't know better. I was like young and a resident, but there is something to it. And now, and again, it's probably a subset and what it is. Celiac disease and alopecia areata, because everything is without gluten nowadays, right? Everybody wants to be gluten-free. The relation is weak. Some people do swear that even when they stop it, they feel better, but I haven't had anyone regrow their hair without gluten. Has anyone? No. But it's still, I always let people do whatever they make without hurting anybody. There is association with inflammatory bowel disease, so there is something that I do pay attention to, and I'm sending people more for GI. So it's part of the pathogenesis. More and more studies are getting done. Bottom line is that when it comes to alpha diversity, there is not a significant difference between alopecia areata patients and healthy controls. So they still have some of the diversity that's similar. But when you look at what's there, healthy people tend to have more Bacteroides, and alopecia areata tend to have different subsets. What's the difficult thing of studying microbiome and giving people an exact thing? Depending on where you live, things are going to be different. People that are very excited still about the poop transplants and all these things to grow things, they can try it and do it, but it's really not legit and indicated. If they have inflammatory bowel disease and C. diff, then it may be. There are 3 cases out there of guys successfully growing and keeping their hair for as long as at least the follow-ups were for a couple of years. So there may be something to it. When patients ask about probiotics or antibiotics, you never really want to give either or because you can push it and things are not perfect. One of the stuff that comes out of our alopecia areata pediatric patients is that celiac in children is really not something that should be played with because a lot of parents want to stop the thing, so there are certain guidelines as to how this should be done. And they should all have a nutritional consult before starting a gluten-free diet. So without realizing it or not, we hit up all these things between she and I. So yes, I dumped it down, but they were all on there, so I should have had you play a scavenger hunt. Thank you so much for your attention.